everybody. Welcome to the Asia Ventilation Forum, or the AVF Podcast. This is the ICU Tips and Tricks series, and I'm Jason Phua. Today, we are very happy to have Dr. Jorge Salluh with us here today, and he's going to talk about how to improve quality in your ICU. So Jorge is a Brazilian critical care physician working in Rio de Janeiro. He's a researcher at the Door Institute for Research and Education, a non-profit research institute. And that's why he's so suited for this discussion, right? Working with outcomes and quality improvement projects for the last 17 years. He's the founder of the Brazilian Research in Intensive Care Network and of the Brazilian ICUs registry, as well as of the Logic consortium, which we'll talk about a little bit more later on. So thank you, Josh, for joining us today.
Well, thanks a lot, Josh. It's a real pleasure and a privilege to be here to share some of our experience and also to learn a little bit from you. Thanks.
Thanks. Maybe we just go straight to the basics. What exactly is quality improvement?
That's a good question. And I'm going to try to make the answer less theoretical, less conceptual, and more practical. I think that as clinicians, we always tend to separate things artificially, right? We tend to put the management at one side and try to put research on the other end and try to say that the clinical part is something completely different. So I think that artificially we've been separating things that actually should be merged. Because when we pose relevant questions such as, should this adverse event have happened? Or is my DVT ratio actually something adequate? Or my VAP numbers, are they up or down? Should they be better? When we're posing this type of practical clinical questions, we're also addressing managerial issues, but also quality improvement issues that can be answered somehow with research methodologies. So I think that everything connects when we are talking about the topic of quality improvement. So I think that quality improvement in brief is trying to tackle problems that we have on our daily basis that we feel are inconsistent with standards of care or the optimal care delivery that we want to be performing for our patients.
Right. So imagining someone out there who's an ICU director, or maybe not an ICU director, someone in an ICU team who sees a problem. How does that someone even start the process of quality improvement? What are the bare essentials? What are the first steps to be taken?
Yeah, so that's also a good question, and I've been hearing it a lot. It even made me and a couple of other physicians write a paper recently, which is like, what are the top 5 priorities of a young ICU director, something like this? Because when you start being responsible actually for the management of an ICU, you may be pretty sure what you have to do in terms of the clinical part, but you're not exactly sure what are the your high priorities, right? And even if you have your gut feeling and you trust that there are some things you have to do, you're not sure that they are ranked high or low in terms of what is expected from you. So I think that to start a quality improvement or to start quality assurance and assessment, the first thing is to have valuable clinical information. So data is the key to start any process. And I think that trying to make it simple, I think that several initiatives, and I think that probably the most known is the European Society of Intensive Care 2012 guidelines, or the task force on quality indicators. Several initiatives have proposed different quality indicators. I think that you have to keep it simple. You have to have a database where you can go through the simple approach of having data on structure, process, and outcomes, at least the basics, and have enough data that you can generate a good characterization of your case mix the resource use, and the outcomes. Because with this type of information, afterwards, you can increase your data set, or you can do at least a first round of evaluation on the rough numbers on the first 2 or 3 months of data collection and try to understand where are the quality gaps, what are your real problems. And I'm mentioning this because sometimes we will buy in and get packages that are ready and say, I'm going to implement the ventilator bundle, or I'm going to implement the sepsis bundle. And maybe you already have good adherence to these practices in your environment. So I think that to prioritize, it's very important to understand what's your patient population, what's this patient profile, what are their outcomes, what are the risk factors, and where are the quality gaps. I think that having short data set, 10 to 12 quality indicators that can be generated from this data set, I think that you can make a very strong case for what you have to prioritize.
Right. I both in quality improvement data as well as just good old research data, I think one of the things that we struggle with, either as an administrator, intensivist, or a researcher, is what is an optimal amount of data to collect, because we can swing both ways. We over collect and it's just not sustainable. It's not doable. It's not feasible. Some of the data cannot be automated. On the other hand, sometimes we realize that when we are done with the data collection, we want to write a paper or we want to do an intervention, and ouch, we haven't collected that data that we think is important after that. So how do you strike the balance?
I think so. First of all, I think that that the scenario that you mentioned is very common, and I think that there's no definitive database. I mean, it's something that you're always looking back and analyzing what you have to add and also what you have to cut. So I'm going to try to take a little risk here and try to talk a little bit about what I think should be the principles of the database. So the first principle, I think, is to start with a core data set. You don't have to start with everything, because probably we as intensivists are always going to exaggerate. You're going to collect more data than we need, expecting that some of our biases or our priors will inform on something that is relevant, and maybe it's not. So I think that having a core data set is very important. And the core data set, although I think it's very challenging to define what is the perfect core data set, I think that in general, we can say that you should think of, when you're reading a paper and you see the first table of the paper, and in the first table of the paper, usually you have what people say, patient's characteristics, resource use, outcomes, stuff like this. So think about what populates this table. And I'm not talking about research, I'm talking about quality improvement. I'm talking about being able to make a good characterization of this population. Of course, you can do it through a research methodology and publish your paper with the data as well, which is great. So I think that the basic demographics, trying to understand, of course, sex, age, where the patient came from before the ICU. Sometimes some information that we don't expect to be important, such as the number of days the patient has been in the hospital before ICU admission, informs a lot on several of the risk factors that we are inserting. But you don't have to have the number of days. You just have to have the date of hospital admission and the date of ICU admission, and then it will be calculated afterwards. So also thinking this way, I think it's important. Another thing is try to keep it simple, but also to be bold in some terms. So for instance, you may keep it simple in terms of having just the severe comorbidities as expressed in the Apache score, or as used in the Charlson Comorbidity Index, for instance. But I think that today we have learned that some features, such as frailty, for instance, are very important markers of risk and vulnerability of the patient, but also are strongly linked to outcomes and to the propensity, for instance, of becoming a chronic critically ill patient. So this is a target population for several interventions, such as early mobility, low sedation practices. So I think that having information on frailty is important, for instance. How do we keep it simple? If you can train everyone to implement clinical frailty scale, that's great. It's a little bit harder if you think you want to be very pragmatic, even though maybe not perfect. Use the modifiable frailty index, which is a very short way to evaluate frailty, but validated. So I think that's the main point. And then after this first box, I would say, which is the background, the premorbid conditions, stuff like this, and the source of the patient, etc. What is the actual diagnosis? What is baseline condition when the patient came to the ICU in terms of organ failures, need for invasive support, and finally the outcomes. And the outcomes are the usual. You don't have to reinvent the wheel. Early readmissions, ICU and hospital lengths of stay, ICU and hospital mortality. People will struggle and say, I'm having trouble here collecting data in my ICU. I'm not going to follow the patient to the hospital discharge. But that's essential. And that's maybe the only part I think that you have to consider being consistent about, because all of the scoring systems that we use in the ICU to evaluate ICU performance, Apache, SAPS, whatever you use, are based on hospital mortality rates, even though they are to evaluate ICU performance. So that's the only thing that needs a little bit more effort. And then I think that other things may be added on the way, like sequential organ failure assessments or ICU acquired complications. But I think that the most important thing is to try to have a very good core data set, which you're not going to change for a long time, because you need to have your diagnosis of your ICU, and then you need to be able not only to compare externally with other ICUs, but also to compare with yourself over time. So I think that the core data set is the key, and then you can just add other layers of process of care, protocols, other interventions as you go, and as you find out what you should prioritize in terms of QI.
Right. I heard you say just now that as you collect these data, you are then able to generate 10 to 12 quality indicators. And so we have this core data set, we add on specific other data that we are interested in over time. But we also, from this data set, we have quality indicators. And presumably, number three, beyond that, we must have targets for the quality indicators, which this whole thing about targets being SMART, right? Specific, measurable, achievable, realistic, and timely. So how then do we choose, based on this data set, the 10 to 12 quality indicators, and how do we target our targets?
That's a fantastic question. So I'm tend to be very optimistic in terms of what we can do with data. I think that we can do a lot with very few information. It's the way we look at data and the way we try to extract value from it that is important. So I think that first, I think that I wouldn't reinvent the wheel. I would go, for instance, if I was just starting a database and a quality improvement program in my ICU, I would go for the 2012 publication from ESICM and go for the quality indicators that are assigned there. Some of them are structured, like having multidisciplinary rounds or having structured electronic reporting of adverse events. And others are actual measurements such as the crude mortality, the risk-adjusted or the standardized mortality ratios, the bloodstream infections, stuff like this. So I would go back to the basics and go to what these recommendations that are now 10 years old, but still apply for the general outlook on quality assessments, at least for the initial quality assessments. But then you introduced a concept which I think is very important, which is what are the actionable indicators? Because I think that we can separate things. We can maybe look at our data and say, we have maybe exceedingly high mortality rates overall, risk-adjusted mortality, like an SMR 1.5, something like this. Or we can say we have longer than expected lengths of stay, or longer than compared to other ICUs length of stay for my ventilated patients, something like this. So that's something that is a kind of red flag and tells me I have a problem there, but it does not tell me what to do, right? So I think that that's why I mentioned in the beginning that we have to combine information. So I always try to look back into what is my population, because even when we are informing on outcomes that are risk adjusted, maybe we're not accounting for maybe having a very elderly population, maybe more than the average of other ICUs, maybe having more frail patients than usual, or maybe having some specific populations that are can be considered different. And I know that when we are using crude mortality or crude lengths of stay, the case mix affects profoundly your results. And even when we're looking at risk adjusted, there's a limit to what risk adjustment actually risk adjusts, especially when you are looking at specialized populations. So I'll give you a practical example. I've been the ICU director for the ICU in the National Cancer Institute in Rio de Janeiro for some years. And of course, it was an oncology hospital. And we have two ICUs, medical ICU and surgical ICU. And in both ICUs, I have to say I had difficulty in benchmarking these patients, because comparing the results of cancer patients, even if I was just indexing them by age, comorbidity, and diagnosis, I would say, okay, these are sepsis patients. And then, suddenly your overall sepsis mortality is something like 60%, and you're thinking, I'm doing something wrong here, right? Maybe I was. And I had to look into the adherence, and there comes the target for improvement, the adherence to sepsis bundles, if I was having more early or late mortality, how was my infection or other complication rates in these patients, and the adherence to some protocols. We implemented checklists to try to improve adherence to sedation practices, to DVT prophylaxis, to stuff like this. So I think that's the actionable part. But there's a part of it also, which is your case mix. And you have also to look at these things together into context. So finally, I think that the targeted part, I think that it's easier said than done. I think that we always tend to say, oh, you can go for actionable indicators, you implement X, Y, Z protocols, and it's going to be fine. And I believe that we have enough data to say that actually this works. I mean, we have performed a study now almost 6 years ago where we evaluated close to 60,000 ICU patients in 78 ICUs in Brazil. And we saw that one of the main drivers of ICU efficiency and of improved hospital mortality was the number of protocols implemented in the ICUs, especially if these protocols were managed by the multidisciplinary team and not by only one part of the team. Protocols that were for the time-dependent conditions, such as stroke, myocardial infarction, sepsis, etc., but also those that were associated with prevention of ICU-acquired complications, such as deep sedation or DVT prophylaxis or infection acquired in the ICU. So I really believe that this improves outcomes. But you cannot say, I'm going to start today and implement 15 protocols, right? It will not work. So I'm going back to the core data set. I'm going to understanding your case mix. I'm trying to understand where you think you're going wrong. Maybe you're not going to need the full 6 months data to evaluate. Maybe you can do, use simple checklists like fast hug model, something like this, and apply it once a week if you're just starting. It will be a sample. It will not be perfect. But imagine that you are in a 20-bed ICU. Over 5 weeks, you will have 100 assessments. And with these 100 assessments, you get a sense of where your problem is. Maybe you have the elevated head of the bed in 95% of the patients, and you don't have to worry about it and to struggle and train people, etc. Because even if implicit, it may be already implemented in your ICU. But maybe you find that your catheter insertion practices or longer duration than expected, or excessive sedation is something that you do not expect. And I think that when we survey people, we find that people are over optimistic in terms of what they say they actually do, as compared to when we measure. So that's why I trust that measuring and maybe going for the sample approach may be a way to find the targets for improvement for when you are in the first steps.
This is very interesting. Your last point about us being overly optimistic. I think it's the way we are trained. We are trained as clinicians. Let's say I'm an intensivist, and I think that I don't need fast hearts. I can remember everything for every patient every single day, right? And then you measure, actually, I'm not that great. So, and hence we need a systematic way to improve the quality, not just for one clinician, but for the entire ICU. And so the question that comes next is there a certain kind of skill set or skill sets that is required for someone who's going to do quality improvement? It could be a generic thing like leadership qualities, etc., or it could be a specific thing, because we keep hearing about things like PDCA or PDSA, lean, etc. What are your thoughts on the generic as well as the specific skill sets?
I would say that, almost kidding, I would say that persistence, resilience, optimism.
Okay.
but and this is true, right? But really, I think that you have to be a team player, and I think that's very important. Protocols should not come from one person; they should be developed among the different stakeholders, the different people that work in the ICU. Everyone should think they are part of it. That's very important. People have to understand why you are doing this. And I will give you a practical example. So delirium assessment, for instance. Most people, clinicians, nurses, respiratory therapists, people that work with patients in the ICU, they will think they can correctly assess the patient without scale, because in the end the scale is just asking all those crazy questions about if fish live in the sea, stuff like this, stuff like that doesn't seem to make sense, but actually they come from very well structured development of questionnaires to assess cognitive conditions on the patients. But when we look in practice, people tend to underrate the importance of these things and think they do it well. And so one thing is, when we see papers versus that evaluate clinical assessment versus structured assessment, we miss a third of the diagnosis. And I remember one situation when I was in the surgical ICU, and I was seeing a patient. He had was a post-operative patient for esophagectomy. So, big surgery. The patient was in the second day. He was sitting outside the bed, looking fine. I went there mostly to see if he was ready to be discharged. And I talked to the patient initially. I was just looking at this sheet here, looking at fluids, et cetera, and talking to the patient. He was, just well. He answered most of my questions very currently. I asked if he slept well last night, et cetera. And I didn't do the CAM ICU, which was something I was promoting very strongly in the ICU at that time. We were doing several studies on delirium assessment, et cetera. But I was so confident that the patient was doing fine. And then I was just turning around to leave the room. But I turned back and said, so I guess you're ready to leave the ICU and go to the ward. And he said, yeah, of course, if you pay for the taxi. And I was like, So I went back, and that silly thing triggered me to do the proper assessment. And then I just called the residents at the time and said, we're going to do this, and you're going to see it's going to be a positive. And it was a positive. And then it made me look to his prescription, look to his lab with different eyes, looking for something that was probably going wrong, And actually there were hydroelectrolytic changes, etc., things that should be corrected and that I didn't have assessed before. So long story short, I think that it's very important that this belongs to everyone, that it's systematic and through the whole system, but you have to engage people. And also you have to identify people that can, although it's a teamwork, you have to identify people that can lead some different protocols. So why not having the ventilator protocols led by the respiratory therapist or their team? Why not having all the nutrition, glucose assessment, etc., led by people in nutrition or the nurses? So I think it's very important. And going back to evidence behind it, so we published a study 2 or 3 years ago now in intensive care medicine, where we were evaluating something close to 130,000 ICU admissions and 90 hospitals in Brazil. And we looked at aspects of staffing patterns and how they correlated with the efficiency of intensive care. And one of the interesting findings when we used unsupervised machine learning approach was that we identified that we could cluster the ICUs according to the autonomy of healthcare professions, and the different clusters of ICUs, 3 clusters actually. We're going to say cluster 1, which was very low efficiency and higher mortality, an intermediate one, and a cluster 3, which was lower, very much lower than expected hospital mortality, excellent results on mechanical ventilation, very efficient ICU care. The differences in staffing patterns were lots, but the most significant finding was that the most efficient cluster was the cluster where you have very high degrees of nurse autonomy. So we generated this nurse autonomy index where we kind of saw the autonomy of the nurse to start protocols, to titrate sedatives, to initiate weaning process, etc. And the higher it scored, the better was the patient outcome, especially for the sickest patients. So I think it's teamwork. I think it's multidisciplinary. And I think that autonomy is the key for everything related to quality improvement.
Specifically for quality improvement, do you use frameworks like the Plan, Do, Study, Act? Or some
I
other...
think that, yes, I think that's always important to have something, some sort of framework. I think that sometimes as you go and you're doing so many things, you almost intuitively apply this sort of framework. But I think that if we look at the structure of the PDCA, for instance, the logic behind it is very interesting, because I think that if we skip the planning phase, for instance, maybe we're going to choose the wrong indicator, maybe we're going to choose the wrong protocol, or we're going to choose a suboptimal approach to measure things, or we're going to maybe be very optimistic that we can do everything and then it's not sustainable over time. So maybe you find that's where you refine the plan for the implementation part. I think that when you are doing the evaluation itself, I think that's when I'm not going to say the easiest part, but I think that's the most intuitive part of it. And I think that checking on results is crucial. And I think that the check part has several components. We don't always break it down this way, but I think that so you're planning and you're implementing your study. But checking, for me at least, is not only looking at results. I'm a real believer in terms of the audit feedback system. I think it's a very good way to work and improve quality, because you're sharing information with the team. People feel that it belongs to them. And also you challenge the team a little bit. So medical rounds, I think, are a very good opportunity to share information with the team inside a quality improvement or a PDCA project. So we did it a couple of times, for instance, with checklist implementation. So I would go and just get the results of, let's say, adherence to DVT prophylaxis. And we would be in the round and looking at a surgical patient, and I would say, what do you think is our rate of DVT prophylaxis in post-op patients here in the ICU? And people would say, conservative, 89%, and I would say, well, last month it was actually 67, something like this. And then that was challenging the team. I think that also made people more aware that, people will make mistakes, that we all are in an environment which is very distressing and also very prone to be interrupted all the time, because you're there doing the prescription of this patient, post-op patient that's coming in, especially if it's not the sickest patient, you're doing it almost automatically, right? You know what to do, and you know what are the recommendations, and you know that you have to prescribe some DVT prophylaxis for, let's say, an oncology surgery patient, that's obvious. And then when you're doing this, another patient's coming in, someone calls you, the surgeon comes in, and maybe you forget it. And then when you get to the next day, it's not there, and maybe the patient is discharged to the wards without the prophylaxis. So I think that in the check part of the PDCA, I think that there is already some action in the process. And this action, I think, goes by disseminating information and using the sort of audit feedback approach that you can do in many ways. You can send this information by email, you can put it on the walls, you can, but I think that the best way is an active way, not a passive way of just leaving information there, is disseminating information, challenging people with the results, maybe having specific discussion involving the team over the topic, but using your own data, because lots of times, and that's why I'm a very big fan of using local databases, is that several times when you were discussing the literature or the recent guidelines, you say, this is not exactly applicable to my patients. It's my impression that actually what we call my patients are more similar than different from what is in the literature. We tend to think they're very special. They're special for us, of course, but they are not as different as we think. But maybe they are sometimes in some specific aspects. So I think that when you put your data into your context and you discuss the evidence-based medicine in this context, I think it's a very rich opportunity to make the full circle of the PDCA.
Right. You mentioned local database, and I think Brazil, you and your colleagues, is a shining example of registries and research networks. We struggle all the time, whether you are in a resource limited or resource rich setting, to collect data. It's always seen as extracurricular, it's not clinical. And so who's going to collect the data? Do you get someone else? Is the data manual? Is it automated? Is it an Excel sheet? Is it part of an internet network registry? For maybe a resource limited area, how do you even start this process, either at a local level or regional or international level?
Yeah, that's a great question. Yet it's very challenging. So I think that the first thing that you have to think about is, of course, we are always aiming to be, that the data abstraction is not going to be a big burden to the team, because everyone's very busy. That's of course important. So I think that the first thing to think about the data set is not as additional work, but at what current work does it replace? Because when we're starting quality improvement projects, we'll listen to the team, and people will say, and they are right, we don't have the time to collect more data. But then maybe you're going to say, maybe you're not going to collect more data. Maybe you're already collecting data on hospital-acquired infections on one end to report internally to infection control. Maybe you are already collecting data for a specific, let's say, readmissions project that's going on in the hospital. Maybe you are already collecting data for the research projects on an Excel spreadsheet, and everything is duplicated and not connected. So I think that the core data set must be the starting point It must be a way that everyone can use this information for something else. So some people can use the core data set for the research projects. You extract data and they use for the research projects. They can use for the quality improvement. They can use for reporting, for accreditation. They can use for different things. So I think that the first thing is to say it's not another database, another data collection. Let's see what it can replace, and let's give wider access to people. I think that's the first thing. The second thing is people will usually say, but it doesn't have specific data on this and that. And I'm going to say, no, we're not going to make it a huge database. Otherwise, it's going to be impossible and not sustainable over time. So let's keep with the core database. And if you're doing a specific project on early mobilization practices, then you collect just the data on mobilization practices. But you don't have to worry about this because someone else is going to collect this data and you're just going to extract and merge with your information. And then I think it's easier to try to have buy-in from the team, finding people that are going to actually have the time or will even volunteer to collect the information. Then you mentioned another thing, which is the automatization of the process. And I think that, of course, whenever you can do it, you should do it. This comes with challenges as well. And they are, in my opinion, half IT and half more, let's say, mundane problems that we have with data in the hospitals. So the IT part, I think it's pretty much well solved these days because there are so many different integration protocols, interoperability standards, etc., that I believe that it's possible to integrate with almost any system today, at least for very basic things such as patient flow, patient identification, some of the outcomes such as vital status at discharge, stuff like this, because these goes for billing. And we know that whatever goes for billing, you can trust, right? That's something that the administration won't let it go wrong. So that's something that's a very good starting point. So if you have very high degree of IT implementation with structured data in your EMR, in your PDMS, something like this, it's easier to do the integration. If you don't have, don't worry, do the integration with the basics, like the patient flow, as I mentioned, administrative data mostly. But it still will save you 20-30% of your time, because especially in ICUs that are very busy and patients are coming in and out, just the process of registering the patient initially and discharging the patient is a lot of work for the manual data entry. So I think that's one part. The tricky part is not the IT part. The tricky part is the medical information part, because even though we live in a world where we have so much information, we have a lot of unstructured information. So I will go into the ICU and I'll see this patient today, and maybe in my notes, I'll not write the diagnosis. I write the diagnosis as septic shock. And maybe tomorrow, because I know the patient actually has a community-acquired pneumonia, I will say sepsis, community-acquired pneumonia / shock. And the other day, someone will write it differently. We're all right, but it's very hard to make sense of this information and feed it into a data set, right? So I think that this is the challenge. I've used this very silly example of the diagnosis because it's ubiquitous, But I think that the challenging part is actually the lack of structured data and the variable nature or notations or forms that we insert data into medical records and make it hard to use in the end. Of course, there's a lot of technology, natural processing language technologies, etc., trying to deal with it, but they're not available everywhere in the healthcare domain. So I think that that's the challenging part for integration. I've seen very interesting solutions, people customizing admission structured admission data for the patients. So they're customizing, instead of writing whatever I want, I will have a diagnostic list, I'll have a comorbidity list, something like this, and you just check that feeds well into your core data set. But that also improves the way the medical information is registered in the end for the overall use in the hospital. So I think that there are creative solutions that can be used for it.
Right. And I think it's very important if I remember you saying earlier on that the reason for collecting this data is also this firstly to see whether you are getting better over time, but also to see how you compare with the others. So this whole concept of benchmarking. And if it's rubbish in, rubbish out, right? If you are comparing 5 different ICUs and they are all calling 5 same things differently, there's no way you can actually compare them. And so I'm talking about registries. And Brazil has got a fantastic registry. We know the BRICnet registry, and it's called ICU registry. Want to share something about your experience with international registries?
Very nice. So I think that the registries, clinical quality registries, have a very important role in quality improvement anywhere where they implement it. When we look at intensive care registries, I think that one of the very important roles was exactly what you mentioned before. When you are participating in a registry, you have to have adherence to a data set, to the definitions of what is severe COPD or what is mechanical ventilation, non-invasive, something like this. So I think that already helps homogenize the data that's getting in, and that is essential for the process of not only having consistent data for your own assessment, but also for the comparisons, the benchmarking process. So I think that whenever registries are implemented, I think that they have a very important role in promoting quality of care, but basically in terms of standardizing the data sets that are used in the ICUs. I think that's a very important point. The other thing is these initiatives started in different countries, different times. That means different critical care, different technologies at the time, different ways to allow data abstraction. So they all have their particular aspects, but they have some common features. They have some core data sets that have share, I think, a very nice overlap in terms of the contents. I think that they have a very strong approach in terms of being consistent and being focused on the quality of the data that's getting in. So I think that I'm going to say that the registries have an important local role in the regions and a very good promise of what can be done internationally. So in the regions, I think that the registries are important sources of information, standardization of data. They drive quality improvement projects in general. They allow you that participate in the registry to look at your own data for the quarter, for the semester, for the year, or for the previous years, and compare with other ICUs in a risk-adjusted way, so that you can also understand if there's room for improvement in your results. Sometimes we are over-pessimistic. We are thinking, oh, we are doing very bad. And actually, when we compare to ICUs that have similar profiles, we're doing well. Sometimes we're over-optimistic. I have already very good results at this year. My comparison over time shows that I'm consistently improving on lengths of stay, on mortality, et cetera, et cetera. But then you go and compare with the real world, and you find that there's room for improvement. There are ICUs that have similar profile to yours that are doing way better. And so there's a possibility of challenging yourself, but also a learning possibility, replicating what these ICUs are doing that maybe you're not doing so well. So that's one thing. Also, I didn't mention, but research, of course. If you have a national database, it's a very rich source of information, not only for medical societies, for policymakers, for the public, but also for research, because there's a huge opportunity. And we saw this with COVID, where most countries that had already in place, and we are just finishing a paper on this, what changed with the national registries of ICUs before and during the pandemic. And we showed briefly that those that actually had a national registry in place before the pandemic were much quicker in terms of providing relevant information to the public and to the physicians and to the medical societies, just as the pandemic began with minimal changes in their data set to adjust for the diagnosis of COVID-19. Whereas where you had to start from scratch, not only there was huge investment, but it took more time to provide the same information, which we saw was extremely valuable for the management of resources, the surge, etc. Then you look at internationally, and I think again the pandemic had shown us this as very important to try to understand what is critical care around the world, how it's used, how does it compare in terms of results, and also the possibilities of connecting this data for quality improvement and research in quality in outcomes research area. And then I think that this connects pretty well with a project that we started a couple of years ago, which is called LOGIC. LOGIC stands for Linking of Global Intensive Care. It's an independent consortium of national registries. So there's the Brazilian registry, in Latin America, Brazil, Uruguay, Argentina participating. In Europe, the Paris region registry, the Dutch registry. Other registries are joining more recently, but I'm mentioning just the ones that were kind of founders of the project. The ANZICS registry as well, and the Critical Care Asia registry, which is funded by Wellcome Trust and the Oxford University for quality improvement in Sri Lanka, India, Pakistan, Nepal. And so all this collaboration with this consortium is trying to do lots of things that we talked about in the previous minutes. So it's trying to propose data sets that are more suitable for low resource settings, to propose core data sets, to investigate what are the international differences in the use of critical care and the outcomes in different regions and how it correlates with things like healthcare investment, the whole expenditure, human development indexes, different stuff that comes from other areas, not necessarily from the medical area, but we know that affect profoundly how we perform critical care. So I think that's a nice initiative. It's now 3 years since we started, and there are several research projects going on. But mostly, I think that the idea is to have more and more clinical quality registries joining. Currently, we have 18 countries represented, and it's been a very nice experience.
Thanks, Josh. I think that really brings this to a nice conclusion. We start off by talking about what quality improvement is, starting small, getting the data ready. What are your quality indicators you're looking at, actionable ones? What are the targets? You talk to us about the qualities of being a team player, the leader skills such as PDCA. And then we then move from local IC registries to national, and then eventually the mother of all registries, which is what you are doing, LOGIC, linking of global intensive care. So any last words to a listener out there who's maybe a novice but really passionate, wants to improve quality? How would you encourage him or her?
Yeah, so I think that we're in the end, we are all in the ICU to improve quality of care, right? So when we are doing our best for that one patient at the bedside, it's to improve care delivery. I think that one interesting concept that we struggle also to conciliate is personalized versus protocolized approaches. And I tend to think that it's maybe because we are discussing it as separate things. I think that when we have more data, more information, more knowledge on the topic, we can improve so much the risk assessment of the individual patient that what we see today as a dichotomized, protocolized approach, it's a yes or no thing for the patient, maybe will be 8 or 10 different options for the different patient profiles. So, and in the end, we're always going to do it better if we do it protocolized, because we leave no one out of the process. So it's going to be personalized, but it's going to be protocolized in a way. So going back to the bedside, to the ones that are starting, I think that it's very important to try not to separate things, break things into the artificial concepts of this is management, this is research, this is clinical, this is protocolized, this is personalized. I have my autonomy to decide better at the bedside. We all want to do better for the patient. We all want to deliver better care for the patient. So trying to understand that these concepts merge, and actually they are all part of our process, and also that what we are doing at the bedside should be integrated to the broader vision of the intensive care unit. So it's a team process. It's being able to work across the different stakeholders, involving also family in the quality improvement processes. I haven't mentioned that, but I think that's a very important part of it. We did a couple of interventions with extended visits, different approaches to try to improve quality through having the family closer, and it does improve several quality indicators. So I think that's some things that we have to think, that actually when we try to explain to ourselves what is intensive care, we put everything in different boxes, right? Because it's easier for us to tell the story. But it's everything at the same time, and everything ends being trying to provide the best quality of care for the patient. So that's all. I think I like to think that everything is about quality improvement.
Thank you. I think that's the beauty of intensive care. Right? And so on the very inspiring note, thank you, Josh. This has been the Asia Ventilation Forum podcast with Dr. Jorge Salluh on how to improve quality in the ICU. We are available on Spotify as well as YouTube. And so please feel free to like, share, subscribe, follow with all your friends so that we can quality improve intensive care units across the world. So the links to some of the references will be on the social media sites, including information on Logic, which is what Josh is leading, which is the registry that links all registries. Till the next time, take care.